Hi, everyone. Let's get started here. My name is Joella Rowland, and I'm a staff editor and the incoming symposium editor for next year. And this breakout session is about concussions as a function of age and gender. How we're all going to get started is we're going to have Dr. Gioia go first, and then Dr. Lincoln, and then Dr. Dissinger, and then we'll have some time for questions at the end. Okay, I will not speak anymore and let the experts do the talking. So let's get started.
See, I'm hitting something here. There we go. Well, good afternoon, folks. My name is Jerry Gioia. I'm a pediatric neuropsychologist at Children's National Health System in Washington, D.C., and I run the concussion program there in addition to a few other tasks on my plate. This session is really to talk about the medical aspects, to give you a sense of what concussion is all about. I'm going to talk about this issue with kids, and in particular, kind of where things have evolved over these 10 years. So it's going to be kind of to some extent, a 30,000-foot view, but it'll also, we'll get into some details as well. Just to let you know, one of the things I do is I develop tests and measures, and so I will disclose that. So 10 years ago, maybe even sooner, we really did not have a whole lot of understanding of what mild TBI is all about. And by the way, mild, you should always put in quotes. Just let me ask, how many in this room have ever had a concussion or a mild TBI before? Probably during those acute stages, you were not feeling like life was just a milder version of your former life. It can rock your socks off. We also had very few healthcare providers that had much of an interest in this area. Our tests and tools that we would use as healthcare providers were somewhat limited. So I certainly didn't promote folks' involvement. There was minimal research funding. I'm not sure it's gloriously better at this point, but at least there's a recognition we need that. And just in terms of general awareness of the risks of mild TBI, of concussion, it was fairly scant. And we didn't have many external rules in place to protect kids. So a lot has changed over this decade, but I think it's important to understand a few basic assumptions here. Number one, we always look to simplify, and I know in the legal world there's black and there's white, and you guys don't use the Crayola box beyond that, right? There's no such thing as a gray Crayola crayon in your box, so it's black and white. That becomes a challenge when you've got a complex kind of organ such as the brain and its injury. The other thing too, despite what you may hear at times in the media, it doesn't manifest in one single way. And there's no one single test or measure or necessarily even one single discipline that has all the answers here. The complexity really requires a multidimensional, multidisciplinary model here. So it's really all about synthesizing together multiple kinds of data. And so let me just say, when we're getting to this issue of concussion, be it in sport or anything else, there's no magic bullet that is going to simply change the story. So the other thing that's important to recognize too is we may prefer to use the C word, concussion. And frankly, if you're being diagnosed by your doctor, or it's your mother, your father, your brother, your sister, your wife, your son, your daughter, your friend, you'd rather hear him say, well, he's got a concussion, as opposed to he's got a mild traumatic brain injury. Same thing, folks. It's really the same thing. And the reason why I'm showing you this ad nauseum is because this is what happens when the brain or the head takes a blow. What you see is that substance inside, which by the way is the consistency of mayonnaise, is being thrown around. It is obviously hooked down by a brain stem and it's anchored, but it's inside a casing, a leathery casing, which has fluid surrounding it. And when it takes a hard enough blow, it stretches, it strains, it throws off the neurochemical systems, and the electrical impulses are impaired, and that's what produces symptoms. It is an index of, symptoms are basically an index of that brain's neurochemical system being impaired. So if we want to look at how we define this, it's basically a complex abnormal physiologic process because of these traumatic energies or forces that are transmitted to that mayonnaise, all right? Now, it can also be that you get hit in the chest or you get hit somewhere else, and it throws your head forward and you get that whiplashing effect. So the way that that brain moves can be due to either a direct blow or an indirect blow. Now, what that does then is it creates, again, rather than typically a substantial structural injury, that is tearing tissues, what we see is that it ends up disrupting, again, the electrochemical, neurochemical processes here. And so as a result, our typical kinds of medical tests like a CT scan or an MRI usually are normal because they are good at identifying the hardware problems, not so good at identifying the software problems. And so again, it's that brain sort of software issue as I think about it rather than the hardware issue. The other thing to know about is that one of the more obvious signs of a brain injury, that is a loss of consciousness, occurs pretty infrequently. In fact, this says 10 to 20%, but it's probably 10%, maybe even less. When they've looked at studies that have really done good epidemiologic surveys, there was one done within the last couple of years in New Zealand, where basically everybody responds. They actually found that it was less than 10% of the mild TBIs had loss of consciousness. What that does then is produce a constellation of signs and symptoms. And really what that means is that we're on the outside looking in, trying to understand how that abnormal brain response has occurred. We know that that can happen in various physical, cognitive, emotional, and sleep-related ways. And then the other part of this, which again is a challenge both from a medical perspective, but certainly from a medical legal perspective, I would argue, is that the duration of symptoms and the profile of symptoms can be quite variable. So one injury does not necessarily equate to another injury in terms of time or in terms of the set of symptoms that manifest. And so you can see that you might have this injury for days, weeks, months, or maybe longer. So again, just to highlight, this is a software injury where we don't have those scans on a clinical level yet that can help us understand that. And this is some research that basically, this is what you actually came for, no doubt, to see good squiggly lines on a graph. This is basically some work out of UCLA that's looked at when you bop little rats on the head and you look at the chemical changes in their brains. And that yellow horizontal line is basically what would be considered the norm. And what we see is calcium and potassium and glucose, and all those things get thrown off, either too much or too little. And what we see then is that becomes some of the fundamental elements of that software system being impaired. What you see is that on the right side of that yellow line, things all begin to come back to the norm. So over time, there actually is recovery of these abnormalities. When we look at the timeline of this, what we see is an injury occurs. It produces, again, a minority of cases, loss of consciousness. It produces a variety of amnesias. That is a loss of information before the injury, loss of the memory for information after the injury. And what we see is those things happen variably. They don't happen to everyone. But they are good indicators of dysfunction. And then what we do is we go on and we look at your cognitive functioning, your balance, we look at your symptoms, and we monitor those over time. What's also very, very important is that what you bring into the injury modifies how your injury plays out. So that if you have a history of attention deficit or learning disabilities, some studies are suggesting that it may take you longer to recover. If you have a history of more recent concussions, that is a repetitive blow, then it may take you longer to recover. If you have a history of chronic headaches, particularly migraines, that may take you longer, as well as anxiety and depression. So other things that affect the brain coming into the injury can modify how that software system repairs itself in terms of the timing, we believe. And this is another important slide to show the variability. Each one of these little points on this graph, in which the x-axis is the number of days to full recovery, and the y-axis is basically the percentage of the total sample. What you can see is that some of those points happen in a few days, some happen in a few weeks, and some happen greater than a month out. And so again, that highlights the variability. You also see two lines. The yellow line there is for those individuals. These are high school athletes who had a history of a prior concussion, and their recovery line just was a little bit slower than the kids without the injuries. So again, variability is the norm here, and why in the medical world we really need to follow these kids carefully and closely. So what you see when you then disrupt the mayonnaise in the head is a dazed, stunned look, confused about events. You may be answering questions slowly, repeating yourself, again, having problems remembering events either before or after the injury, losing consciousness, again, maybe briefly and only partially, or behavior changes. And then the cognitive kinds of symptoms, things like difficulty remembering and concentrating and just slower in thinking. People talk about this foggy or unclear way of thinking. All those physical kinds of symptoms, headache, fatigue, dizziness, those kinds of things being pretty common. And then the emotional kinds of things, a much greater sensitivity, irritability to stressors, and then disrupted sleep. So those four categories are important to know about. So our challenge, quite honestly, and this is really the public health challenge and the things that we've been involved in for a number of years, is how you take that issue of this injury that is basically invisible and give people the proper knowledge to know what to do. And that's where our CDC has come in. And if you go to cdc.gov/concussion, you will get to all of the toolkits that we've developed over the last 10 years. And that's them. Various kinds of handouts, various kinds of videos that are there. And these are for parents, for coaches, for kids, for schools. So all good materials, and they are all free of charge. Your tax dollars paid for it. Actually, one sign that Washington, actually it's really Atlanta, can do something to benefit us. Recently, actually not recently, a few years back, we actually put all this information on a smartphone app. As I tell people with all the research I've done over the years, my kids recognize that Dad did something useful by developing a smartphone app. So the concussion recognition and response app, if you have an iPhone or a Droid, it's free, download it, and it allows you, if you are concerned about whether somebody's had a concussion, to walk through the steps that you would be observing for, and it gives you some good guidance as to what you do next. I won't go through that in detail here. But basically, it's all about recognizing force or blow to the head, knowing that signs or symptoms may follow, and knowing what questions to ask and how to monitor that, suspecting an injury, and then doing the right thing, which is responding by, with kids, knowing you sit them out. When in doubt, you sit them out, and you make sure they are then properly evaluated by a medical person. So then what we've done over the last 10 years is also build our medical toolkits. This is the physician's toolkit, again on the CDC website, came around in 2007. Mickey Collins and I were two of the primary authors of this. And then we've had 4 international conferences that have looked at the research and developed consensus recommendations. The American Academy of Pediatrics, the American Medical Society for Sports Medicine have put out position papers. You'll notice that these dates are all relatively new. This is again telling us that the last 10 years there's been a lot happening here. The American Academy of Neurology giving their evidence-based guidelines. Again, pediatrics helping us look at issues of school, and then more recently the Institute of Medicine issuing their report on youth sport concussion. So we now have a lot of people paying attention to this, but one of the things that the IOM said is we still have a fair amount of limitation in how we go about handling this, because we don't have a particularly good set of research data to guide us, particularly for youth. So again, our work over the years has been to develop a variety of clinical tools, whether it's symptom assessments, whether it's cognitive tools. So we now have better tools in our hands, at least, to begin to put this in place. We have neuropsychological testing. Some of you may know this as baseline testing. What we know is that this injury impairs these cognitive functions, attention, memory, speed, executive function, and it also impairs your emotional response. There's a lot of strengths to this in that it really helps as a tool to objectively identify those problems, but there's also some limitations in that lots of things can affect these functions, which means that these things need to be understood as one element in an assessment. They're not the end-all and be-all, and sometimes you hear the cry for baseline testing, that will save my kid. No, it won't. A good professional that knows what they're doing with this information in their hands, amongst other data sources, will help save your kid. Remember, brains are and their injury are complicated. Single measures, single tests alone aren't going to do it. We now have a lot of materials, again, for schools to help kids as they return. This is the school toolkit we put out just a few years ago. So, where are we today? I'd say that public awareness probably cannot get much higher. We clearly, within the sport-related MTBI concussion world, see that recognition is happening. I would argue, though, that it's not yet translating to some of the other injury types. I will tell you that in our clinics, we're seeing way too many kids for sports and not enough kids for motor vehicle crashes, falls, and the many other reasons why kids are injured. We are expanding our research knowledge, but as the IOM and the American Academy of Neurology report says, we have a long ways to go. More and more healthcare providers and clinics are being developed around the country, and that's good so that families can have access to care. We are now providing more clinical tests and tools so that we can evaluate and hopefully manage that properly. And as some of you may know, all 50 states and DC now have youth concussion laws in place that are trying to educate the stakeholders and ultimately provide some guidance in terms of care of these individuals. So we ultimately want to make youth sports better by educating and teaching the fundamentals, learning how to recognize and respond appropriately, reducing contact, certainly eliminating inappropriate contact to the head, enforcing rules, modifying behavior. So every time I hear somebody, moan about the ref throwing the flag, I say, too bad. You know what, we need to err on the side of caution. We need to understand that we don't know everything right now, and some of the things that are being asked for, particularly in youth sports, I think are unreasonable in the sense that we need science to guide what we're doing. We have to also appreciate the law of unintended consequences. And just be careful what you read or see. It's not always where life is. Okay? So I'm going to let my colleagues take over here, but we ultimately want to make sure that we keep kids' brains good and healthy and safe. Thanks. You up one. There.
Good afternoon, everybody. I'm Andy Lincoln. Nice to be here with you all. I noticed the speakers have been so good today, and people have covered a lot of things. Just so happens that I was going to cover a lot of those same things, but we'll make it through. So this session is somewhat about age and gender and variability in that regard, so we'll be touching on those things. I'm director of the MedStar Sports Medicine Research Center uptown, based over at MedStar Union Memorial, and so glad to share some of these things with you. We'll just touch on the epidemiology that's been mentioned a number of times this morning. Take a brief look at some mechanisms of injury and how they vary by age and by gender. Look at biomechanics of sport concussion and injury threshold, which is, has come up several times as being quite a difficult thing to get our hands and minds around. And then just touching on what also has been touched on before, but some of the unknowns as we try and move forward. So this number you see often, this 3.8 million sports-related brain injuries each year. We know that's not true. We know that's a vast underestimate, but now we're beginning to understand some magnitude of the underestimate. So perhaps 4 or 5 or more greater than that at this point. I'll show you some data on why that might be. We also are understanding that often, going back to motivational issues and reporting, we've got a high percentage, 30% of our high school football players may not be reporting their symptoms, maybe higher, 40, 50% in some cases. And I think this gets back to this educational messaging and awareness of, well, what are the risks and what are the incentives? Because they do see their professional counterparts or heroes who I think set the tone in a lot of cases, and we talked about that this morning. So going back to 2002 to 2006 data, 1.7 million traumatic brain injuries per year, and we'll see a graph that suggests those data are really that's a dramatic undercount. So those who don't seek care aren't getting included here. Those who don't report aren't getting included here. Over 1 million seen in emergency departments. Highest risk are youngest kids, 0 to 4, primarily from falls. The 15 to 19-year-olds, primarily from sports. And then, as Dr. Faden mentioned this morning, the elderly and the falls and the concussions, also a major public health issue. So resulting in some hospitalizations and over 52,000 deaths when you combine firearm, motor vehicle crashes, and elderly falls. Now, looking more specifically at concussions, CDC estimate of 173,000 for young folks in sport and rec-related injuries. This was beginning to increase, this estimate was beginning to increase to about 250,000. The vast majority are male, and as my mentor would say, this largely is a function of the testosterone poisoning that are associated with males participating in more aggressive sports, more contact activities, and higher risk activities. And this 10 to 19-year-old is really kind of the sweet spot in terms of playing sports where there's enough energy and so forth that they are going to be at risk for concussion. I'll share some findings from a study from a couple of years ago, and this is based on data across the river in Fairfax County, Virginia, where they've been collecting data from 1997 essentially through, well, we stopped collecting it here in 2008. So just looking at 12 sports, 6 boys sports, 6 girls sports, I think no surprise at all that football represents the majority of concussions seen in the youth sport or scholastic sports scene, 53%. And the rate is absolutely the highest. So if you're a football player, you've got about an 11-fold risk of a concussion compared to your baseball player. In the girls' sports, our soccer players are at higher risk, and actually they register here with the second highest rate after the boys' football. So then we've got our lacrosse and basketball. Now, if you look at the bottom, cheerleading has a low rate of 0.06, but if you look at the actual incidence or number, cheerleaders rank second after soccer, and that's, of course, because of the falls from height issue that they're often exposed to. Although my niece suggested that it's not just the flyers who are at risk, it's also the kids on the bottom who get hit by the flyers or the kids running in. So we've got a couple things to worry about there. This is the trend that we've seen, and the boys, so the boys rate, which if you take the football cases out of this, almost is identical to what the girls' rate is here. So football really represents the differential between the boys and the girls. So what's changed in these 11-year span? Was all of a sudden sport getting much more dangerous? Unlikely to happen. Although I think the games have changed over time. For those of us who played high school or college sports, the games these days are not those same games. They're played more aggressively, the kids are bigger and faster and stronger, and so in terms of kinetic energy transfer, that's really, the brain or the body hasn't necessarily changed, but the way the kids are has changed. And then there's the issue of symptom reporting. And thanks to better education, better awareness, hopefully kids are answering the question now and reporting this. I've had several conversations with high school football players where I ask, how many of you have had a concussion? And a few will raise their hand. Okay, well, how many of you have had your bell rung? Oh, well, yeah, bell rung, that's me. But I've never had a concussion. Well, guess what? So it might be that in 2002, they would not have raised their hand, but in 2008, they would have. So think of those earlier numbers as being based on data from the earlier part of this range. If we break this up into the different sports, it's not just a function of the collision sports, which are really football and boys lacrosse, but even the incidental contact sports, where you're not supposed to get hit, we see it there too, which may suggest more awareness at that point. So we also see it in both the helmeted sports and the non-helmeted sports. Kind of interesting. And in the sports for which the games are essentially the same, so soccer, basketball, softball, and baseball, we find that our girls have twice the rate as the boys do. And we'll touch more on that in a second. Now lacrosse, which you all are in Maryland, so you know that boys lacrosse and girls lacrosse are not the same sports by any means. In lacrosse, the boys still had about a 50% higher rate than the girls lacrosse players. So I want to make sure that that's not considered same sport. So here is our female to male rate ratio in those same sports, and it's oddly very consistent around 2.0 girls to boys. More concussions occurring during the soccer, so the error bars are going to be a little bit narrower at that point. But we're seeing this here. This correlates also with what we're seeing in the collegiate level. So what's driving this difference, this gender difference? Why are we seeing girls at twice this risk? And there's a lot of speculation. We don't have good answers, but there are some questions about, in general, we know that girls in our society are more likely to report or seek care. So this may be more of a reporting bias, or that may contribute to it. There may be a hormonal component to it and a susceptibility for the girls. And then thirdly, it may be a difference in structure, that is skeletal structure, muscular structure. That is the torso and the neck strength. Boys may be better able to absorb energy that's being imparted to the skull. And that's, again, another hypothesis. None of these really have definitive answers to them. We're getting to the point where we're recognizing this, and then we can explore what's driving those differences. Talk a little bit about mechanisms of injury. We did, so going back to this gender difference, looking at some NCAA data, Randy Dick published this a couple of years ago. These are mechanisms of concussion for soccer players, collegiate soccer players. And so not surprisingly, higher numbers among the women. Player contact, more frequently the case of injury mechanism for the men than the women. Contact with the surface and contact with the ball, more common among the women. And a lot of people are very concerned about heading the ball. And is that a potential intervention to reduce concussion? Some of the other research on mechanisms of concussion in soccer suggests that it's very few are ball related, that it's much more the case where you've got player-to-player contact, players going up for a header, players and hitting head-to-head, players going up for a header and getting elbow to head. And they were able to find this in some European leagues, and once they kind of tamped down on the officiating, they were able to bring the concussion rate down dramatically. So to try and figure out what was going on with youth lacrosse concussions or scholastic lacrosse concussions. We videotaped high school injuries in Fairfax County, Virginia, and we actually caught 34 concussions on the boys' game, 11 on the girls, over a period of 2 seasons. So from about 1,000 injuries, that's what we got. A couple things were a little bit surprising. One thing was for the girls, the level of play. All of these injuries occurred at the varsity level. So we had suspected that maybe the JV, where they don't know the game as well and they play more recklessly, that may be more of a risk factor. And that turned out not to be the case. So it looked like actually the higher levels of play, more aggressive play, was where the injuries were occurring with the women. All of the boys' injuries were body-to-body contact. Not surprising, it's a collision sport. That's the nature of that game. The majority of the girls' injuries were from stick-to-head contact. And so I'll tell you now that there is a work in progress for a standard on head protection for the women's lacrosse players. And the big question is, well, to protect against what? And there's not a whole lot of data, but we've shared these few numbers. But this also gives you a sense of how sparse the data is to be able to build a standard that's going to hopefully do what is intended and protect them. Just kind of intriguing penalties and whether or not they were called. 24%, so about a quarter of the concussion cases in the boys resulted in penalties. Now this data is prior to a rule change that eliminated intentional head-to-head contact. That went into effect actually after we showed the CEO of U.S. Lacrosse these data and said this has no place in our game, so kudos to him for wanting to take that out. Let me break for just a second to show you a couple of these incidents. These are very brief. Well, provided that it should. Okay. Okay. What I want you to pay attention to is where this player's attention is focused. All right? Well, one thing we found was, well, watch it again. Okay, so he is totally unaware that he's about to get laid out, right? This is our vulnerable player. And we've seen the NFL look at these and make rule changes to try and protect receivers going across the middle. I think this is a kind of the low-hanging fruit for where leagues may be looking to intervene. If you think about how he was bracing for this or not, well, compare that to our next case. Okay. Now this is a situation where both players actually ended up getting concussed on that hit. But they see each other, they prepare for the blow, and what do? What would you do if you were about to get hit? Right? You tense up, you use your core, and compare that with our first player. So thinking of it more mechanically and how we're actually doing testing these days on helmets and representing, so we've got a testing dummy, a hybrid 3 model for our testing. We're not looking at all at what's going on with the neck and the trunk, which I think is a major component to what's going on here. Okay, so there's a couple of examples of these boys' full body contacts. If we compare that, this is one of the girls' cases where we had better video. Did you see that there? So she got hit in the head with the stick right there. And they didn't even blow the whistle until, she kind of grabs her head but very mild. And in general, a lot of the girls' injuries were milder than the boys. I have very poor data to support this, but I do wonder whether or not there's a different threshold of energy to cause concussion for boys and girls. I think there may be, just like there may be for, and again, going back to more of a structural question. So, all right, just touching base now. There's been a lot of discussion today about accelerations and contact forces. So I just want to, I know when I saw this the first time, it really helped to get a sense of it. These are data from Trey Crisco and his colleagues who've collected hits data from three, at this point, there were 3 Division I football teams over 4 seasons. And this is the distribution of impacts associated with that. Peak linear accelerations measured in Gs with one hit recorded of up to 300 Gs. But the median here at 20 Gs, and 20 Gs, you see players score a touchdown or something, give each other congratulatory headbutt kind of thing. That's about what you're talking about. That's the most common level of impact, is that 20 Gs. The 95th percentile, about 50 Gs here. And then very few really high level hits after that at this. So going back to that earlier conversation that we were having about sensors and where do you establish a threshold for an alarm to go off to alert your medical provider, and at what point are you going to have false positives, false negatives? We don't know. We don't know. But this is the kind of distribution that comes into effect with a study like that. The group down in North Carolina, Kevin Guskowitz and Jason Mihalik, published a paper on this elusive injury threshold. It identified that concussions can occur at these lower impact magnitudes, such as 30 Gs, so really seemingly very mild, and yet less than half of 1% of head impacts greater than 80 Gs result in concussion. Linear acceleration appears equally important to cause concussion as angular acceleration, and we can get into lots of arm wrestling over that. Different folks have different perspectives on the importance of angular versus linear. And then we've got cases where athletes can sustain this high number of head impacts over the course of a season, maybe on order of 1,000 times, even exceeding 80 to 90 Gs, never have a concussion. And then lastly, they suggest that impact magnitude doesn't necessarily relate to clinical outcomes. So whether someone gets really lit up or a seemingly mild blow can still have either a severe or mild outcome. And getting a sense of that just brings you into how difficult this is to deal with. This was a paper that came out in 2012 that kind of changed a lot of things in terms of youth football and Pop Warner. It's based on very few subjects who were involved here, but they compared head impact exposure at the youth, high school, and college levels. So, in college, it's essentially a job that these guys have, and they're exposed to about 1,000 impacts per season. At the high school, about half of that, and at youth, just a little over 100 per season. In terms of linear accelerations, for a long time with 7- and 8-year-olds, the conventional wisdom was that these kids are just too small, they don't have the mass, they don't have the speed to generate enough force to even worry about. Well, guess again. So their median impacts about a quarter less than the high school players, and their 95th percentile, surprisingly, relatively high compared to that group. So based on this paper, which I think outfitted about 7 kids, 7-year-olds, Pop Warner, in the week after this was published, came out and said, 2 contact practices a week, no more. So not a lot of data to base that on, but made a huge policy decision. And since that time, we've had essentially the NFL and their collective bargaining agreement do the same thing. And the Ivy League has adopted similar limited physical contact approaches. Just touching on some of the unknowns again, as Jerry mentioned, the Institute of Medicine came out with a really comprehensive review of the literature on this and really put out a strong call to improve the science and challenge the culture, a lot of what we talked about this morning. So just to review a few things that are missing for us to move forward and that we need to develop: a lack of data concerning overall incidence of youth-related concussions in youth. Okay, we've got really good data at professional leagues, pretty good at college, some high school data, almost nothing at the youth level. We've got that one paper that I just showed, and I did a study of youth lacrosse. Other than that, there's a handful or less on this type of information because we don't have the providers there. We don't have athletic trainers doing it. And if we rely on coaches to report concussions in their kids, I wouldn't trust those data to be worth much. Limited evidence that current helmet designs reduce the risk of sport-related concussions. There's actually a paper that came out just in the last couple of weeks that suggested different helmet designs could have differences in protective effects. So this is wide open. Little research on changes in the brain following concussions in youth, or differences between males and females. And even though, as Jerry was describing, the huge sea change and improvement that we've had just in the past 10 years, it's still developing in terms of how to actually diagnose and manage concussion. We kind of know what not to do sometimes, but we don't always know what's best for each individual. Little empirical evidence for the optimal degree and duration of physical rest. So we're still struggling with that management. And then I think one of the really big questions, we really don't have good evidence, long-term evidence on the effect of repetitive head impacts or multiple concussions on long-term neurodegenerative disease. Again, what Dr. Faden was mentioning this morning. So it's a fun problem, it's a bit of a mess, and I think together we're making strides, but we got a long way to go. Thank you. Dr. Dishinder.
Thank you, Andy. Good afternoon. I'm a bit of a fish out of water because I'm going to present some data not related to sports. What's wrong? Can't hear me?
Yeah, I can do it. Just go to the slide.
Okay.
And then just advance, you just do this, or you can do it.
I'm Pat Dishinger. I work down the street at the National Study Center for Trauma and EMS, which is part of the University of Maryland School of Medicine. And this is a study, we were funded to do this study by the Department of Defense a number of years ago. And just as a little bit of background, most of the work I do is on motor vehicle trauma, and I have a large study where we identify people that come to the trauma center, which is up the street, the R. Adams Cali Shock Trauma Center very large level 1 trauma center. So we identify people in motor vehicle crashes. We send out a crash reconstructionist, and we interview the patients in the hospital, and we follow them up over time. We collect the detailed injury information and CAT scans and so forth, and we meet once a month in a group and present the physical evidence from the crash scene and the clinical evidence and the interview evidence to try to, the purpose of the study, which is funded by NHTSA, National Highway Traffic Safety Administration, is to identify injury mechanisms, how you broke your femur or how you got your head injury and so forth. So a number of years ago, one of the orthopedic surgeons I was working with said, "Pat, we have to do something." He said, "I see these people in the clinic for their ankle fracture, and I get this, psst, hey doc, would you come out in the hall? You know, my husband's not quite right, you know, my son or whoever it is, it's not his ankle fracture, there's something wrong." And this Dr. Burgess was saying to me, "We don't know what to do about it, and somebody really needs to look into this." So I applied to the Department of Defense and was funded to do this study. And it's, I think 55% of the cases in this study then were in motor vehicle crashes. But the purpose of the study was to try to look at early predictors. Could we find something early on in these patients to predict those who had persistent post-concussive syndrome? So that's what I'm going to present right now. We identified 180 people in the course of the study who had a mild TBI, and got their consent to participate in the study. We asked them to come back for they had an initial visit. We asked them to come back at 3 to 10 days, 3 months, 6 months, and a year. And if they couldn't come back, we tried to at least interview them subsequently. So these were all patients with blunt trauma. As I mentioned, the majority were motor vehicle, some were falls, and I remember there were a few equestrian incidents. I don't remember any particular sports. So we defined mild TBI as a transient loss of consciousness, peritraumatic amnesia, or other alteration in mental state. And these, we excluded people who had focal neurological findings or with positive CT scans indicating brain injury requiring intervention. The mean age of this group was 35 years. I think the reason I was invited to the conference is to just bring more awareness to the older population, and a lot of the literature is on kids playing sports, as we've heard today. And also to bring awareness that there are other mechanisms of injury. And as Dr. Faden mentioned, there's even less information about the elderly population and TBI. Half of our patients, about half, had high school education or less. The majority were employed or in school previous to their injury, and as I've said, about half were in motor vehicle crashes. We used this concussion symptom checklist, which has also been discussed today, that was completed at each visit to address these 12 symptoms. Dr. Goya mentioned also problems with sleep, which we did not include in this, unfortunately. So in this slide, what we did is group the symptoms together. So the red here are the physical symptoms, and the emotional and cognitive are down here. As you can see, the physical symptoms increased, they were higher than the cognitive and emotional symptoms. All symptoms pretty much increased at the 3 to 10 day visit, declining somewhat thereafter. The physical symptoms declining approximately to where they were pre-injury. People come in and report they had headaches and so forth previously. For the physical and emotional symptoms, however, you can see that they peak, they decline, but oftentimes they're not coming back to the baseline level. So we defined, you'll find this defined variously in the literature, but we defined post-concussive syndrome as the persistent presence of 4 or more of these 12 symptoms over time. So you can see that at the 3 to 10 day mark, the vast majority of people had post-concussive syndrome, which again drops off, but even down here at 3 months, which I'm going to be discussing today, 41% of the patients had 4 or more of these symptoms. And here you can see in this univariate analysis for each of these symptoms, the ones that we found to be significant predictors of PCS at 3 months were light and noise sensitivity. You can see people that reported noise sensitivity were 3 times more likely to have persistent PCS than those without. Anxiety is another one. Patients who reported anxiety at the 3 to 10 day mark were almost 4 times more likely to have PCS at 3 months, and so forth. However, when we put all of these variables into a multiple regression analysis, because some of them are correlated with each other, it boiled down pretty much to well, let me go back to this a minute. It boiled down to anxiety, which you can see has a large odds ratio, as I mentioned, and also to noise sensitivity, which is not difficulty hearing, but you're suddenly acutely aware of noise. Like I remember one patient reported that, oh, my mother was, fixing something for Christmas in the kitchen and she was cracking walnuts and it was driving me crazy. So it's this noise sensitivity, or what's called hyperacusis. But when we then put in a multiple regression analysis all these variables, what it boiled down to was noise sensitivity and anxiety. However, then we pursued it a bit further and found out that there's an interesting interaction with regard to gender and anxiety. For patients with no anxiety, females shown here in the red, for patients with no anxiety, you can see that the prevalence of PCS was higher in men than in women. But interestingly, there's a complete flip. If you look at patients who reported anxiety, there's a significantly higher proportion with PCS among women than among men, which Dr. Faden, who spoke this morning, is very interested in this and says that the findings in animal research are very similar. So just to summarize this very, very briefly, we found that physical symptoms were very prevalent at 3 to 10 days, but everybody had them, so they weren't prognostic of people that had persistent long-term problems. The incidence of 3-month PCS was significantly higher among women with anxiety, as I just showed you, at 3 to 10 days post-injury. And noise sensitivity remained an independent risk factor for PCS at 3 months. There's not much in the literature about this issue of noise sensitivity. However, I did see an article from Australia that was a qualitative analysis done by I guess they were psychologists, I can't remember exactly, like occupational psychologists or something, and they found that people, they thought this was a key symptom because people reported they had such problems with it, they could no longer think properly, they couldn't go back to work, they couldn't go out socially because the bar they used to go to was too noisy, and so there was sort of like this cascade of events. That was their theory. So then we went further with this data to try to look at who returned to work, whether we could predict inability to return to work. So again, we wanted to look at these symptoms in the 3 to 10 days following injury and find out which symptoms, if any, would help us to predict who was able or unable to return to work at 3 months. You can see, as I mentioned previously, the majority of people were working before their injury, working or in school before their injury, 90-some%. It dropped down dramatically 3 to 10 days following their injury, and it rebounds somewhat, but not back to baseline at 3 months. And interestingly, what we found is that there were 6 of the 12 symptoms that were stronger predictors than the remaining with regard to inability to return to work. So the 6 are shown here: noise sensitivity again, blurry or double vision, difficulty concentrating, trouble thinking, depression, and irritability. So for people who had all 6 of these symptoms, none of them were able to go back to work at 3 months. However, for those with none of the strong symptoms, 9%, only 9% were unable to go back to work. And you can see there's a big difference with regard to the blue symptoms, or what we're calling the weak symptoms. So with regard, I'm skimming through this, but we found no association between age, gender, education, and inability to return to work. We did find that baseline depression was significantly associated with inability to return to work. And as I just mentioned, we found 6 of the symptoms were shown to be the strongest risk factors for inability to return to work. Also, with each additional increase in one of them, there was an additional 15% decline in ability to return to work. I should mention, I didn't have time to go through it all, but we conducted balance testing, which was difficult because these patients who have come to a level 1 trauma center rarely had an isolated TBI. They frequently would have upper extremity or lower extremity fractures or other injuries. So there was a woman on campus here that had done a dissertation on balance dysfunction as a predictor of outcome from mild TBI, and was very interested in that. And lo and behold, the people in physical therapy had this NeuroCom balance master, which looks like a phone booth. And the patient would stand in there, and then it would sway you, and then electronically it records your compensation for that. But unfortunately, anybody who had an upper or lower extremity injury, we could not put them in this thing. We also had extensive neuropsych testing. We used military testing, which is called the ANAM, Automated Neurometric Assessment Model or something. And that it includes your reaction time and all these other tests, which I can no longer remember the name of, but none of them were predictive with regard to trying to identify early predictors of PCS. In addition, we did a blood test, which is called the S100, which was theorized to be a biomarker for outcomes from concussion. Again, we found no relationship. So it boiled down pretty much, despite all of this work, to these self-reported symptoms, and pretty much to what I've told you, which is noise sensitivity and anxiety with regard to PCS. And I think that's all I brought. Yes, thank you.
Thank you very much to our speakers. I'm going to now open the floor up for questions, and I'm actually going to take advantage of the fact that I'm standing by a microphone right now and ask the first question. So I know that some of our speakers touched upon the fact that there is some disparity with age. Is there a difference in impact based on age? Do people who are, whose brains are still developing have a worsened impact? Or is that kind of mitigated by the fact that, the sports that they're engaging in, they're engaging with people of their own size, so there's kind of less force going there. Kind of what is the difference in age with concussions, I guess, is what I'm trying to ask.
No, the only study that I'm aware of actually is a follow-up to what Andy had showed with the Virginia Tech group, and that was actually their partners, the Wake Forest group. And They looked at actually the follow-up data, some additional data, 3 years. That was, I think, after maybe the first year. The younger kids overall, their magnitude was lower, but, you know, and definitely the older kids had a higher magnitude, but it was still, you know, significant magnitude. So there may be some differences there, but that was a very select, you know, study, football only. So you know, that's where we still need so much more data.
Yeah, I think we've got an interesting situation where, in terms of all other injuries, we know that the kids heal so much faster than adults. But that doesn't seem to hold in this case. It seems to be reversed, or so we think. Exactly why that is, I don't necessarily understand, but that's where we are.
Yeah, so that gets to the outcome side of it. And again, the data right now is largely looking at high school students compared to college and professional. It's mostly male and it's mostly football. So you're kind of narrowing the scope, and the high school players were taking longer than the collegiate, taking longer than the professionals. We don't have any data to add, you know, pre-high school kids to that, and we don't have any data to add girls to that at this point either.
Okay, now I'm going to open the door. Manny?
So my name's Manny, I'm a third year. I remember maybe 2 years ago, Colt McCoy was the former quarterback of the Cleveland Browns. He sacked at the end of, I think, the second quarter of the game and was knocked out. He sat out for the rest of the second quarter, then halftime, and he came back into the game in the third quarter. He said after the game, or maybe a day or two later, that he didn't remember the entire second half of that game, yet he was playing. Is it common for memory loss to happen with, I guess, different levels of concussions, or?
Yes, I mean, it's actually is so the post-traumatic amnesia or anterograde amnesia happens in probably 40% of these injuries. Basically, what's happening there is that the part of your brain that stores memories is not working well, yet your motor system works fine, your sensory system works fine. Obviously, he could remember, you know, for the moment the plays in order to carry it through. But that ability of that brain really chemically to stamp in the experience was impaired. Brain's an interesting organ. It is.
I remember that hit as well, and it was fascinating, I think, both for the mechanics of what was going on as well as the policy, because I believe the league did have a policy at that time. But just preceding that hit where he got wiped out by the Pittsburgh linebacker, and he was out. Everybody on TV saw it. However, the medical staff was tending to another player on the bench. They didn't see anything. So after they brought him to the bench, they evaluated him. He exhibited no signs or symptoms of concussion. They had no reason. Of course, they didn't see him. Yes, he had been lying on the turf for several minutes. There was no criteria at that point to keep him out of the game. I remember the next couple plays, they got down to the goal line, and there was a close-up of him calling the signals at the goal line, and you could see his eyes, and I said, he's not there. You could tell he was not there. And it was after that incident that they decided, we're going to place an athletic trainer in one of the boxes so that even though the medical staffs are, if they're occupied tending to another injury, these things won't be missed. So we had that situation where millions of people on TV are watching this, and the staff that's responsible for doing this missed it. Now, I think going back to earlier discussions about policy and can we legislate this or that, I think it really brings an interesting question about when you talk about youth sports, where we've got the majority of our participants in sports at the youth and rec levels, and yet we have very little oversight, very little recognition of what's going on. And actually, Jerry came up with a concept that I thought was ingenious of taking a parent and assigning a test to them. I don't know if you want to.
Yeah, in essence, what we were trying to come up with is a public health solution, sort of the 911 solution, and it follows that blow to the head, any change in function, that kid needs to at least be looked at, and that's why we have either our clipboard stickers that the CDC provides or the app or something that's going to guide somebody. And when in doubt, that part of the little jingle there is if a parent who typically is not medically trained, but hopefully has some level of training of at least recognizing, and being able to ask and observe those signs and symptoms, if they cannot rule out that that's, a problem, then they sit that kid out. So you err on the side of caution there. So, it's a public health solution, and not expecting perfection, but certainly improvement over what we had in the past.
Any other questions? Yes, sir?
It may be tough to disentangle with athletes because they're chronically physically active, but is there any evidence that physical activity, which promotes brain plasticity in certain regions, would help facilitate rehabilitation from concussion?
Yes, yeah. So there's some good work being done both in Montreal with children, at Montreal Children's, and in Buffalo. John Letty and Barry Willer have published probably now about, 2 or 3 papers that have looked at the outcomes, and then 2 or 3 other papers that have looked at the methods. But yes, the whole idea is that by increasing activity level carefully, you do it so that you don't go too high on the symptoms. You don't want to blow up the symptoms. That by circulating blood flow, typically in someone who is stagnant, being quote-unquote resting, then what you're doing is you're stimulating a number of important chemicals into the brain. One is the brain-derived neurotrophic factor, BDNF, which has been shown, particularly in animal models, to be important for brain growth and development, but probably also brain repair. It also stimulates the endorphins, which now, as we say, is sort of the happy medicine, right? It helps mood and probably alertness, as well as likely some other neurochemicals. So that's being studied now in terms of that. The observational studies that have been reported have shown that, at least for those folks who have had a more persistent post-concussion recovery period, it seems, at least observationally, to facilitate their recovery. What we need now is a good, clinical trial to look at that.
And Dr. Faden also mentioned this morning in his basic science research with rodents, similar findings. The first speaker this morning, I don't know if you heard him speak, but
I missed that,
so you could probably look up his references also.
Yeah, the work that not only Alan Faden has done, but also at UCLA. So Barry's work at Buffalo and Isabelle Gagnon in Montreal is based on the animal literature that shows if you actually allow an animal in their typical environment to start to physically work out too soon, what they showed was actually a delayed recovery. But if you held them for a period of time, allowing that initial recovery process, that initial neurometabolic system to basically recover, and then started them midway through, in their case it was 2 weeks, you actually promoted recovery. So there seems to be a timing factor in addition to the dose factor.
There's probably a psychosocial component to that as well. Kids being isolated for too long can develop depression, or just that isolation from their teammates, their schoolmates, and having them rejoin and get active, or akin to the light duty return for workers after injury. There may be some beneficial approach in guiding that, but it's small error bars on either side of that. How much exposure and when.
Okay, we have time for one more question, and then we're going to go for a break. Whitney?
So in your discussions, there, you take the injured brain as it comes, and that there are certain preconditions that affect recovery time. Do any preconditions make your mayonnaise more delicate and more susceptible to concussions?
That's a good question. So I don't know if you heard that. Is there any precondition or premorbid risk factor that seems to make the brain more vulnerable to the force itself? We don't know that. Probably. I can tell you that there are some behavioral factors that may not make the brain more vulnerable, but put you in situations where now the injury is more likely. So kids, for example, who have attention deficit hyperactivity disorder, who are kind of running out and doing things impulsively, kids who have learning disabilities who aren't reading the signs correctly or don't remember the rules well, kids who have chronic histories of behavioral kinds of problems, getting in fights more. So there's certainly those preconditions in that way. But as far as what may predispose, we're not sure. There's some theories, maybe folks who are dehydrated, for example, where now there is less sort of fluid in the brain. Is that now going to somehow affect risk? I mean, those are all theories. A lot of work to be done, though.
Okay, thank you very much to all our panelists, and now we're going to go for a break before our last panel of the day.